Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Welcome back, listeners. This is our 7th and last episode on ovarian cancer. Today, we're going to be exploring the nuances of surgery for ovarian cancer. Sydney, what are our learning objectives for today?
Our learning objectives are to explore patient and disease-specific factors that can influence surgical decision-making, to discuss methods and to assist in prediction of optimal and complete cytoreduction, and to explore the utility of secondary cytoreduction for ovarian cancer.
Recall back to our advanced stage epithelial ovarian cancer episode that optimal cytoreduction is defined as less than 1 centimeter of gross residual disease, and that ideally cytoreduction to microscopic or no gross residual disease is the standard of care in ovarian cancer if feasible. This recommendation is based mostly on observational data, which shows improved overall survival with optimal resection and even better when resection is to R0. Retrospective and subgroup analyses of prospective trials have also demonstrated this improved overall survival benefit in patients that are optimally cytoreduced. With this understanding, it's important to answer the questions of how to select patients in whom optimal or complete cytoreduction is likely to be achieved. And secondarily, how do we determine which patients can tolerate the aggressive surgery needed to achieve optimal or complete cytoreduction?
Both of these are excellent questions. We'll tackle the optimal debulking question first. Two main ways to predict the ability to achieve an optimal cytoreduction are via laparoscopy or preoperatively using a combination of imaging and tumor markers. The Fagoti score is a laparoscopic scoring system originally described in a 2008 publication, which was designed to evaluate the ability of laparoscopy to predict optimal cytoreduction. In this study, 113 patients were included, some of whom were undergoing primary debulking surgery and some who were undergoing interval debulking surgery. All patients had advanced ovarian cancer and underwent laparoscopy followed by exploratory laparotomy with the same surgical team. In both surgeries, 7 areas of the abdomen were evaluated. The authors found that the least accessible items on laparoscopy were mesenteric retraction, bowel infiltration, and stomach infiltration. Said another way, these areas may be discovered on XLAP when not detected by laparoscopy. During the laparoscopy, each area was scored with a 0 or a 2 to indicate resectability, and findings were then compared to the findings of laparotomy. A 2 is given for the following. For peritoneal carcinomatosis with unresectable peritoneal involvement or miliary distribution, for diaphragmatic carcinomatosis with widespread disease, infiltrating or confluent nodules on most of the diaphragm, for mesenteric disease with large infiltrating nodules or involvement of the upper root of the mesentery, for which limited mobility of intestines is a key finding, for omental disease with tumor diffusely involving up to the greater curvature of the stomach, for bowel infiltration requiring probable need for bowel resection, or miliary carcinomatosis on the loops of bowel, for stomach infiltration with obvious involvement of the gastric wall, and lastly, for liver surface metastases with any surface lesions greater than 2 centimeters. The minimum, quote, predictive index value is 0 and the maximum score is 14. A score of greater than or equal to 8 is associated with an inability to optimally cytoreduce. Specifically, at a value of 8 or higher, the risk of performing an unnecessary XLAP in which optimal cytoreduction will not be achieved is 40.5%. In the study, a score of less than 8 had a 100% positive predictive value for reducing inappropriate unexploration. In other words, this cutoff would minimize the number of times a laparotomy is not performed in a patient who actually could have been optimally cytoreduced.
In 2015, an updated retrospective study was completed by Dr. Fagotti's team, Petrillo et al., to reevaluate and update the laparoscopic scoring system in the context of now known improved survival with complete resection as opposed to optimal resection, and with increase in the use of upper abdominal surgery. Retraction of the mesentery and miliary carcinomatosis were shown to be invariably associated with unresectable disease, and thus their contribution to the score were now excluded. In other words, if a patient has these during laparoscopic assessment, we should not be doing a primary debulking surgery because complete resection will not be achieved. The remaining 6 categories did remain in the score. A value of greater than equal to 10 out of 12 was found to have a 0% chance of achieving complete resection, and the risk of unnecessary laparotomy was 33%. As such, the authors concluded that with this updated scoring system, a score of greater than or equal to 10 should be strongly considered for triage from primary debulking surgery to neoadjuvant chemotherapy with interval debulking surgery.
Fleming et al. Published prospective data in 2018 evaluating progression-free survival with the use of Fagotti screening. Over a 2.5-year period, 621 patients with advanced stage ovarian cancer were evaluated, and 488 met inclusion criteria. Patients who did not have evidence of carcinomatosis, were surgically unresectable by imaging, or were medically inoperable did not undergo laparoscopy. Ultimately, 215 patients had a laparoscopic scoring assessment, which was reviewed by 2 surgeons. The discordance between independent reviewers was only 2%. Out of the 215 who were assessed, 125 patients had a Fagotti score less than 8. Out of those 125, only 111 had primary debulking surgery. In 6 of those, the patient refused, and 8 other times the surgeon elected to not perform surgery even though the score was favorable. R0 resection was achieved in 88% of patients who underwent primary debulking surgery and in 74% who underwent neoadjuvant chemotherapy with interval debulking surgery. Progression-free survival was best in the primary surgery with R0 resection group with a PFS of 23.5 months, followed by primary surgery with an R1 resection, 17.5 months. These were followed by neoadjuvant chemotherapy with an R0 and R1 interval debulking resection with 15.5 months and 12.9 months, respectively. There were 5 laparoscopic trocar complications, 2%. These were all GI tract injuries during entry. This is a good reminder that for people with advanced disease, laparoscopic entry can be dangerous and choice of entry location needs to be carefully considered.
Based on these studies, the NCCN states that providers can use laparoscopy as a tool to determine whether optimal cytoreduction is feasible. It's interesting to note that evaluation by laparoscopy prior to cytoreductive surgery was used in many of the neoadjuvant chemotherapy trials. In fact, a laparoscopic assessment was required in the Scorpion trial. In this trial, rates of optimal cytoreduction were very high in both the primary debulking surgery and neoadjuvant chemo with interval debulking surgery groups at 93 and 99%, respectively. Aside from laparoscopy, how else can we predict optimal cytoreduction?
In 2014, Sweden et al. Published a study using clinical and radiographic markers to predict debulking success. On multivariate analysis, they found the following 3 clinical and 6 radiologic criteria to be predictive of suboptimal debulking: age greater than 60, CA 125 greater than 500, ASA class 3 to 4, and 6 radiographic markers: enlarged suprarenal lymph nodes, diffuse small bowel adhesion or thickening, lesions in the small bowel mesentery, lesions in the root of the SMA, lesions in the parasplenic area, and lesions in the lesser sac of the stomach. Each of these lesions had a cutoff of greater than 1 centimeter for inclusion. Suboptimal debulking was linearly associated with the number of markers a patient had. With greater than or equal to 9 positive markers, the rate of suboptimal debulking was 74 versus 5% if no preoperative criteria were met. There isn't necessarily consensus among individual providers or institutions about whether laparoscopic evaluation or a combination of markers and imaging should be used, especially when considering the constraints of medical resources like limited operating room time. However, whichever scoring system you decide to use, you should use it consistently to become proficient at doing so. Ultimately, one should optimize getting their patient to the treatment that will be most effective for them in a timely manner.
Okay, that makes sense. So I feel like we've covered how you best predict whether you can or cannot achieve an optimal or complete cytoreduction. But to achieve this, some of these debulking procedures can be pretty intense, and some of our patients may not tolerate them well. Do we have any guidelines or tools to help us determine who these patients might be?
We do. Recall the ethical principle of non-maleficence, do no harm. It's important to remember that patients who experience greater surgical morbidity may also be delayed in starting adjuvant chemotherapy, which actually can be detrimental. In 2019 and 2023, Narasimhulu published a series of studies which developed and then validated a triage algorithm to reduce 90-day surgical morbidity and mortality. They determined that a patient is high risk for morbidity or mortality if one of the following is met: albumin less than 3.5, age greater than 80, or age 75 to 79, in addition to ECOG performance status of greater than 1, stage 4 disease, or complex surgery likely. If the patient is determined to be high risk, the authors recommended triaging that patient to neoadjuvant chemotherapy. You can find the figure in our show notes at readysetgyo.com.
Wright et al. In 2011 and 2012 published two studies. First, evaluating risk factors for surgical morbidity, and then its effect on delay in starting adjuvant chemotherapy. They found that surgical morbidity was greatest among elderly patients who were treated with multiple procedures. The composite complication rate rose with age, with a 17% rate seen in patients less than 50 years old versus a 31% rate in patients greater than 80 years old. Complications included surgical site complications, medical complications, infectious complications, increased transfusion rates, and prolonged hospitalizations. In the subsequent study, they found that 28% of patients experienced some delay in starting chemo if they received surgery first in the treatment paradigm. The extent of cytoreduction was associated with delay in chemotherapy, as were postoperative complications. The article suggests that if the delay from surgery is greater than 12 weeks to chemotherapy, this starts to affect cancer-related outcomes.
Okay, that's really helpful. I now have a better understanding of how to determine which patients may be optimally or completely cytoreduced and which patients may have greater surgical morbidity and/or complications in the primary setting. What about recurrent disease? Is there a role for secondary cytoreduction in patients with ovarian cancer?
There is, and multiple studies have evaluated the feasibility and utility of secondary cytoreductive surgery. Let's walk through the trials together, and then we'll wrap up the secondary cytoreduction topic with the NCCN consensus statement. Rose et al. Published a prospective study in 2004 evaluating secondary cytoreduction after adjuvant therapy for people that had a suboptimal debulking at the time of their initial surgery, defined as having greater than 1 centimeter of residual disease. The patients received 3 cycles of adjuvant chemotherapy. If their disease hadn't progressed and they had a residual tumor less than 1 centimeter, they were then randomized to having a second surgery right away versus finishing the remaining 3 cycles of their adjuvant chemo. There wasn't a difference in PFS or risk of death between the two arms, essentially negating the role of secondary cytoreductive surgery in the frontline setting. Chi et al. Published guidelines and selection criteria for secondary cytoreductive surgery in patients with recurrent platinum-sensitive epithelial ovarian cancer in 2006. It was a retrospective review of patients undergoing secondary cytoreduction at one institution to identify potential prognostic factors. They found that the longer the disease-free interval, the better. Patients with more than 30 months of disease-free interval had a median overall survival of 51 months versus 39 months if the disease-free interval was more than 12 months, compared to 30 months of survival for disease-free interval of 6 to 12 months. They also found that the higher number of sites of recurrence, the worse the overall survival. Overall survival was 60 months versus 42 months versus 28 months for one site of recurrence versus multiple versus carcinomatosis, respectively. Finally, residual disease at the time of secondary cytoreduction was also predictive of survival.
In 2007, Solani et al. Published another retrospective study of 55 patients, all of whom underwent secondary cytoreduction with the goal to identify factors associated with improved survival. Patients were included if they had complete response to primary therapy, had greater than 12 months between initial diagnosis and recurrence, and had less than 5 recurrent sites. 74.5% of patients had complete cytoreduction in their secondary surgery. Independent predictors of improved overall survival included a diagnosis to recurrence interval of greater than or equal to 18 months, limited number of recurrent sites, and lack of residual disease after secondary cytoreduction. Age, tumor grade, histology, CA-125 level, presence of ascites, and tumor size were not associated with survival. Interestingly, imaging correctly predicted the number of sites of recurrence in only 62% of cases, perhaps further suggesting the utility of laparoscopic evaluation. In 76% of cases of incorrect imaging assessment of recurrence, there were more sites of recurrence than previously thought.
The AGO desktop OVAR 1 and 2 trials were designed to develop a predictive score for secondary debulking in the OVAR 1 and to validate this score in OVAR 2 for recurrent ovarian cancer. Desktop OVAR 1 was a retrospective study of 276 patients who underwent secondary cytoreduction. The authors found the only independent factor associated with improved survival was a complete resection, with a 45-month versus 19.7-month survival. Factors associated with improved chance of complete resection included ECOG performance status of 0, stage 1 or 2 disease, complete resection at primary surgery, and ascites less than 500 milliliters. In Desktop 2, 516 patients with platinum-sensitive first or second relapse of disease were screened. Of these, 51% had a score positive of all 3 factors: complete resection at first surgery, ECOG score of 0, and absence of ascites more than 500 milliliters. 129 of these score-positive patients underwent surgery with a 76% complete resection rate. 11% of those who underwent surgery required a second surgery, and there was a perioperative mortality rate of 0.8%.
These studies culminated in the Desktop 3 trial, published in 2021 in a European cohort. This was a randomized control trial of secondary cytoreductive surgery in patients with recurrent ovarian cancer. 407 patients were enrolled. Inclusion criteria were first relapse after a platinum-free interval of 6 months and a positive AGO score of the aforementioned 3 criteria. They were stratified by platinum-free interval of 6 to 12 months versus greater than 12 months and randomized to investigator's choice chemotherapy alone versus cytoreductive surgery plus chemotherapy. Complete resection was achieved in 75% of patients, and the median overall survival was 53.7 months versus 46.0 months, favoring cytoreductive surgery. The best outcome was seen amongst patients with a complete secondary cytoreduction, with a median overall survival of 61.9 months. It's important to note that patients with an incomplete resection actually had an overall survival of 28 months, meaning that incomplete secondary cytoreduction had a survival detriment compared to chemotherapy alone. The complication rate was reasonable, there were no 30-day deaths, and the quality of life was similar between the 2 groups. The biggest takeaway from this series of studies is that complete resection in secondary cytoreduction matters.
In the same year, a similar study, SOC1, was published in a Chinese cohort. There were 357 patients enrolled, and they were included based on an I-model score less than or equal to 4.7. I-model is an international model to predict resectability. In general, the enrolled patients had a lot more disease than in Desktop or GOG 213, which we'll talk about further in a moment. Most patients in this study had more than 20 sites of disease. Despite this, the surgeons achieved complete resection in 77% of patients. However, The average hospital stay was around 2 weeks, and the surgery durations were very long, with a lot of upper abdominal surgery. And the reoperation and death rates from surgery were similar to normal primary cytoreduction rates. Progression-free survival was improved with surgery at 17.4 months versus no surgery at 11.9 months. Overall survival was not different. The benefit was limited to people in whom macroscopic complete resection was achieved.
GOG 213, published in 2019, evaluated the utility of secondary cytoreductive surgery in patients with recurrent platinum-sensitive ovarian cancer. There were two separate objectives: one, to assess the benefit of bevacizumab, and two, to assess the benefit of secondary cytoreductive surgery. 485 patients were included in the surgery arm. They were deemed to be, quote, completely resectable by the investigator-assessed resectability without any standardized scoring method. These patients were randomized to cytoreductive surgery followed by chemotherapy plus minus bevacizumab versus chemotherapy plus minus bevacizumab alone. Most patients had less than 2 disease sites at the time of surgery, so as mentioned before, these surgeries were much less invasive and complex. Complete resection was achieved in 67% of patients. The overall survival and progression-free survival in the surgery plus chemo plus minus bev versus chemo plus minus bev alone arms were not significantly different. The surgical arm was ultimately closed early after a futility analysis. In this study and this group of patients, secondary cytoreduction did not show a benefit. However, most of the patients in this trial received bevacizumab, which complicates the results a bit in terms of assessing the efficacy of secondary surgical resection. Maya, want to distill these studies down for us? Any thoughts about why the results from Desktop 3 and SOC1 were both positive studies and are different than the GOG 213 surgical arm?
Absolutely. The first thing to note is that Desktop and SOC1 both had higher rates of complete resection than GOG 213. Remember that there was a standardized assessment of who would most benefit undergoing resection in the first two studies using the AGO score and the iModel score. Secondly, there was dissimilar use of bevacizumab in each of these studies. 84% of patients in GOG 213, 23% in Desktop, and 1% in SOC1 received bevacizumab. The Desktop and SOC1 trials were not designed to study this, so we can't extrapolate from this data. Finally, the selection criteria was different in the different studies. Namely, Desktop had highly favorable and strict selection criteria.
Recently, in 2023, Conte et al. Evaluated the role of minimally invasive secondary cytoreduction in patients with recurrent ovarian cancer. It was a retrospective review of all patients who underwent minimally invasive, being N of 62, or open, N of 214, secondary cytoreduction at a single institution. The overall complete resection rate was 95%, and there was no difference in completion rates in MIS versus open groups. Early postoperative complications were higher in the open group. Factors predictive of success of MIS surgery were neoadjuvant chemotherapy at first diagnosis and single or oligometastatic disease. 3-year post-recurrence survival rate was 76 and 84% in the MIS and open groups. While not statistically significant, the authors state that a small sample size could be masking a true survival difference.
There are several trials ongoing to further evaluate the utility of secondary cytoreduction, including in the platinum-resistant disease cohort and in patients after PARP inhibitor therapy. Synthesizing the outcome data from these studies is challenging. Progression-free survival is almost always going to be extended, but overall survival is a more meaningful marker. It's difficult to show an overall survival benefit in the setting of maintenance and improved therapeutic options. Most patients will do well already, or maybe even better, with chemotherapy and maintenance without suffering the surgical morbidity. However, these trials do provide rationale for considering secondary cytoreductive surgery in strictly selected patients, such as was done in the Desktop trial, and especially in those who may not be able to receive bevacizumab maintenance.
We hope you enjoyed and learned something from today's episode. Here are your key takeaways. Primary debulking surgery is associated with the best prognosis for patients with advanced ovarian cancer when complete resection to no gross residual disease is achieved. Morbidity and mortality from primary debulking surgery are higher than with neoadjuvant chemotherapy and interval debulking surgery. And if complete resection cannot be achieved, the risks may outweigh the benefits. Patients who are older and who undergo more complex procedures experience the greatest surgical morbidity. One proposed triage algorithm incorporates albumin, age, ECOG score, stage of disease, and likelihood of complex surgery into a score that can help reduce the surgical morbidity associated with cytoreduction.
Multiple methods can be used to help predict the chance of optimal cytoreduction. Sweeton et al. Described a system that incorporated age, CA125, ASA class, and imaging findings to predict suboptimal debulking. The Fagoti score is a laparoscopic scoring system that analyzes 7 different components to predict ability to achieve optimal debulking. A cutoff score of greater than or equal to 8 reliably demonstrates the ability to predict suboptimal debulking.
Secondary cytoreduction has been evaluated in several RCTs. While the Desktop 3, SOC1, and GOG 213 trials had differing results regarding survival benefit from secondary cytoreduction, in well-selected patients, this can be a good option to improve PFS and OS for our patients. Criteria for patient selection for consideration of secondary cytoreduction surgery should include platinum-sensitive disease, single or oligometastatic recurrence, and ability to achieve no gross residual disease at planned secondary cytoreduction.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson. We'd like to thank Dr. Shannon Rush, faculty at UPMC Magee Women's Hospital, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.